if came to you patient with shortening of breath and dizziness and cold hand and feet, headache, palpitation, difficult in concentration, first possibility you suspect is anemia. Also, check the patient if there is a graving of history of graving non-food substance, pica, such as dirt, ice, or clay, brittle nail and hair loss, glossitis, maybe suspect iron deficiency anemia. Also, restless leg syndrome is character of iron deficiency anemia. Also, if feeling by tingling or numbness of hand and feet, difficult walking, and memory loss or glossitis, also vitamin B12 deficiency. If present jaundice, yellow discoloration of the skin and eye, also suspect here hemolytic anemia. If there is a frequent attack of infections and bleeding, also suspect aplastic anemia. So if you are all these symptoms present, you should be check CBC, hemoglobin level. If hemoglobin level, when you said anemia, if hemoglobin level in pregnant women less than 11, in non-pregnant women and children and less than 12, and male less than 13. If you found that, that's mean is case of the anemia. Look also for other parameter of CBC. If you found low platelet, low white blood cells, that means pancytopenia is go direct for bone marrow aspiration where there is a serious condition. If hemoglobin less than 7, so you should be in the stable patient should be transfusion is recommended. From 7 to 8, and there is underlying condition or active bleeding or underlying cardiovascular, this should also consider transfusion. All right, this is urgent thing. So if pancytopenia, go direct for bone marrow aspiration. If hemoglobin less than 7, go direct for blood transfusion. If the patient is cold condition and you are search for the cause, after this stabilization the patient, you should be consider what's the cause of the anemia here. Generally, what's most common causes of anemia? Generally, iron deficiency anemia is about 15%, and anemia of chronic disease about 20%, and anemia due to blood loss is about 10%, and megaloblastic anemia is about 10%, and hemolytic anemia 5%. So if hemoglobin low and other parameter is normal, that's mean anemia. So I will search on the cause of the anemia and look for MCV. If MCV less than 80, that's mean microcytic. From 80 to 100, that's mean normocytic. More than 100, that's mean macrocytic. If I found the MCV is low than 80, that's mean microcytic, I will search on the cause. What's most common causes here? First one, iron deficiency anemia. Second is anemia of chronic disease. Third, thalassemia, and lead poisoning and sideroblastic anemia is rare also. But if I found MCV is low, I will search to the cause, exact cause. I will do what? I will do ferritin and the transferrin iron binding capacity. I want understand first what's mean ferritin and transferrin iron binding capacity. Iron storage in the tissue and the form of the ferritin, and the iron go in the blood on the carrier called transferrin. Transferrin is a protein from the liver. Transferrin iron binding capacity, that means iron binding capacity to transferrin. And transferrin saturation, that means present of saturation of transferrin receptor from iron. All right. So I will do ferritin and the transferrin iron binding capacity. If I found ferritin is low and the transferrin iron binding capacity is high, that means iron deficiency anemia. If I found ferritin is high and the transferrin iron binding capacity is low, that means anemia of chronic disease and thalassemia and sideroblastic anemia. All right. So I will go to see the first differential. Ferritin is low and transferrin iron band capacity is high. That is confirmed as iron deficiency anemia. But if I found ferritin is high and transferrin iron binding capacity is high also, that's also no, that's mean also is iron deficiency anemia. Plus there is maybe inflammation due to any other cause, whereas ferritin also is a marker for inflammation. All right. So if I found typically ferritin is low, less than 30, and transferrin and iron band capacity is high, that's mean iron deficiency anemia. Is only enough for give treatment only and go on? No. In this situation, you should be considered search of the cause of iron deficiency anemia. Maybe most common cause is menorrhagia in the female. If asked on the history if there is menorrhagia, that means go on give iron replacement therapy directly, no need more investigation. But in the postmenopausal women, and if there is any and in male, you should be asked about any bleeding like biles, like any other cause. If there is no definite bleeding from GIT, I will do occult stool. If there is occult stool, blood in stool, I will do colonoscopy. So is my message here, if there is no clear cause of iron deficiency anemia, or in the postmenopausal women, or there is any history of weight loss, and in male, you should not give iron replacement only, but you should be do colonoscopy to exclude colon cancer. If I found is ferritin is high and total iron binding transferrin iron binding capacity is low, that's mean maybe chronic disease. So I ask about TB or cancer or any other chronic disease. If I don't found any chronic disease, so I cannot exclude thalassemia. I will go in an examination, examine spleen to see if their spleen is enlarged, or in the thalassemia also spleen become splenomegaly. There is splenomegaly. But in the thalassemia trait, maybe not palpable spleen or spleen is not larging. So, but here also in thalassemia, I found the MCV is very low, less than 70, maybe reach 50. So from 50 to 70 here in the thalassemia. So I will do, if I suspect, I will do hemoglobin electrophoresis. But in the beta thalassemia major becomes symptomatic from the children, and there is dysmorphic face, and there is other symptoms become symptomatic in children, not come an adult. But in thalassemia, beta thalassemia major, I will found hemoglobin F more than 70%, normal is than 1%, and thalassemia minor maybe not symptomatic. So when I will do hemoglobin electrophoresis, I will found hemoglobin A2 more than 3.5 and hemoglobin F less than 3%. All right. So I will diagnose here is like thalassemia. And other rare causes like sideroblastic anemia. Sideroblastic anemia is iron overloaded, and maybe congenital, like X-linked or due to alcohol or leads or isoniazid or chlorophenicol. Investigation here and treatment here, vitamin B6, and diagnosed by bone marrow, but it is rare. All right, and lead poisoning when there is history of patient like painter or working in battery, but it is two rare causes. All right. Second most common cause, second differential diagnosis for anemia, normocytic. That's mean MCV from 80 to 100. In this condition, what I will do? In this condition, I will do a reticulocytic count. If reticulocytic count is normal or low, that's I go direct to bone marrow aspiration. So here in the if MCV is low and I will do ferritin. I diagnosed iron deficiency anemia and present occult stool, occult blood in stool. I go direct to colonoscopy. This is first important message. Second important message here. If I found MCV is normocytic and reticulocyte count is normal, so is normocytic with normal reticulocytic count, I go, that's equal direct to bone marrow aspiration. This is very important message in the anemia. Not forget, please. So here, if reticulocyte count is normal or low, I will do bone marrow aspiration. If bone marrow aspiration is abnormal, like hypoplastic and aplastic anemia, or infiltrating like leukemia, or this erythropoietic like myelodysplasia. But if the bone marrow aspiration is normal, that means maybe secondary anemia like renal or liver disease, or a very important endocrine problem, like most common hypothyroidism. Very important this. If I found reticulocyte count is high, that's mean maybe acute blood loss, maybe hemolysis. So in acute blood loss, there is a history of acute blood loss. But if there is no history of acute blood loss, that's mean hemolysis. Hemolysis notes here, hemolysis that's mean lifespan of RBCs not like normal 120. If that's mean decrease. If in decrease lifespan maybe reach to 2 to 20 days in severe anemia. But you should be observed. Maybe sometimes there is hemolysis, but not observed like jaundice. Why? Where is the bone marrow can increase work to eightfold to replacement anemia, and also conjugation of the liver may be increased to eightfold. So not appear anemia or jaundice until the hemolysis increase more than eightfold of normal. To search on the cause of the hemolysis, you should be note that there is proteins called haptoglobin. It is an intravascular hemolysis, all right, and direct comb test. If I found direct comb test is negative and haptoglobin is normal, that's mean what? That's mean extravascular cause for hemolysis, and this is 2S, hemolytic anemia, sickle cell anemia, and spherocytosis. So I will go direct to hemoglobin electrophoresis. If I found hemoglobin S, that means sickle cell anemia. If I not found hemoglobin S, that means I will do osmolarity Faragit test to confirm spherocytosis. If comb test is negative and haptoglobin is low, that means also two cause for hemolytic anemia like paroxysmal nocturnal hemoglobinuria and G6PD. Paroxysmal nocturnal hemoglobinuria mostly occur pancytopenia. 26% of patients give history of red urine in the morning. Undiagnosed by here by flow cytometry and management by biological therapy, eculizumab. And paroxysmal and G6PD is most common cause in here, but I cannot do measurement for the G6PD until 2 to 3 weeks after acute attack of hemolysis, right? But if I found direct comb test is positive and haptoglobin normal, that means warm autoimmune hemolytic anemia. If direct comb test is positive and low haptoglobin, that means cold autoimmune hemolytic anemia. If I found MCV is high, more than 100, I will also do reticulocyte count. If reticulocyte count is high, that means also in hemorrhage and hemolysis, and I will go in differential and more investigation like normocytic. But if reticulocyte count is normal or low, I will do for investigation. If I want more research, I will do vitamin B12, folic acid, and thyroid function and lipid profile. All right. If I found vitamin B12 is deficiency, I will go search more to give search on history If the patient may be Crohn's, maybe there is a history of operation in the terminal ileum.